program on safe and effective management of pain and addiction will be presented by Dr. Carl Christensen and Dr. Mark Weiner. Dr. Christensen has practiced in the fields of OBGYN and gynecologic oncology as well as addiction medicine. He currently works with pregnant women with addiction at St. Joe's in Ann Arbor and also works at St. Joe's Recovery Specialist treating people with chronic pain who are detoxing or tapering off of opiates. He is a past president of the Michigan Society of Addiction Medicine and the current medical director of the Michigan Health Professional Recovery Program for Don Farm, and for Don Farm. Dr. Christensen works with the U.S. Attorney's Office, the DEA, and local law enforcement as an expert witness for opioid prescribing cases. Dr. Weiner is the section chief of addiction medicine and serves as the medical director of substance use disorders at St. Joseph Mercy Hospital, Ann Arbor. He's also the medical director of IHA Recovery Specialists. He's the chair of the planning committee of the American Society of Addiction Medicine course, Pain and Addiction, Common Threads, and is member of the planning committee for the American Society of American Medicine annual meeting. He's an editor of the ASAM Pain and Addiction Handbook. Dr. Weiner is the immediate past chair of the Board of Trustees of Don Farm. Please join me in welcoming Carl and Mark.
Thank you, everyone, and welcome. I am Mark Weiner, as it says. Thank you for that great introduction. I want to follow the instructions where you don't ask questions until the very end, but if you have a burning question, please interrupt Dr. Christensen. So, you know, it was interesting. I was talking with someone just before we went up here, and they were asking a question about the science behind a lot of the things that we're going to present today. And it's really interesting that for addiction and pain, there is really not a lot of what we would call double-blind, randomized studies that indicate exactly what you should do. And we're still at a point where we use a lot of common sense and experience with the different issues of pain and addiction. So you're going to hear a lot of experience. Dr. Christensen has a little, I think, some science in his slides. Not too much science in mine. Mine's more focused on sense, hopefully good sense. So my job today is to talk about pain and addiction and what it feels like when you're a person in recovery who has pain. I treat patients like this all the time. Mostly anyone who's in pain in general is afraid, but patients who have addiction are doubly worried and afraid, not just of experiencing pain, but of getting a drug that will lead to relapse or being allowed to suffer in pain. There's a lot of questions. And so that increases the level of anxiety. And higher levels of anxiety often cause more pain. The fears are not just with the patients, but with family members and friends. We're going to talk about the myths regarding pain management and the myths about managing pain in patients with addiction, and some suggestions for improving outcome and preventing relapse when a person in recovery has pain and interacts with the medical profession. So, like I said before, general feeling is fear, just a lot of fear. But the person with substance use disorder has all kinds of fears. And these are the kind of things I've heard people say, you know, I'm afraid the doctor is going to give me something so that I will relapse. And then there's a patient who will become honest and say, boy, I hope the doctor gives me something so I can relapse. It'll be like a free lapse, you know? Not really my fault, their fault. Patients think they're going to suffer because they have addiction and no one's going to treat their pain. Some people say, I should suffer, I deserve to suffer because I have addiction. I've had patients explain that, you know, if I'm going to be in pain, I might as well just go relapse. Makes sense to the person in sort of not so stable recovery. People think, well, there's really nothing a doctor is going to do or should do because I'm a drug addict. I should be safe. This is a thought some people have. I should be safe because I like my doctor and he would never prescribe anything that would jeopardize my recovery or my sobriety. I told the doctor I'm in recovery, so now I'm going to be safe. And the feeling that some people have is my doctor is probably a drug addict anyway, which is not always a bad thing. the family members feel almost identically. They feel like that the doctor is going to make their loved one suffer. That the doctor will, sometimes, I've heard people who are not going to enough Al-Anon meetings say, I hope the doctor gives him something so he'll relapse. I liked him better that way. Yeah, you've heard that, huh? No? Patients are going to be left to suffer because they're in pain. They think that's what doctors do to addicts. Some patients who are the loved ones of the person with addiction feel that the addict should suffer because of what they did to them. There's nothing a doctor's going to do, and the doctor's probably a drug addict. These are similar fears that go between the patients and the family members and friends. And like I said, the situation presents itself as significant fear and anxiety, and that in and of itself, when it's very high, colors the relationship. When you're on if a doctor is not well trained in this and the patient is highly anxious, they are aware that something is wrong, and they themselves become very anxious, and there's a transference of that anxiety. I do a lot of work with doctors, both at from the level of medical student all the way up to attending and residents and fellows, and what I try to do is help them look at patients who have addiction with compassion, because it's hard to connect with compassion when the doctor is full of anxiety. And I'm sure the reverse is true. It's hard to have compassion for the doctor when you, the patient, is full of anxiety. So we're going to do some true-false questions. There is no wrong answer unless you're wrong. Okay, first, the only good medicines for reducing pain and suffering are opiates. Exactly. Well, you know, I was leading with that one, right? That was easy. But I'll tell you, that's what a lot of people feel like. They feel like, well, if I can't get opiates because I have opiate dependency, they're going to give me a second-rate treatment plan that's not going to work, and I'm going to suffer. That is not always the case. It really depends on the patient. It depends on the situation. The effect of opiates in terms of reducing pain differ from patient to patient. And the couple of things that I've seen in my experience is that patients who have dependency, especially those on opiates, have very poor pain control on opiates. Some of that could have been due to their exposure to opiates over time, that they develop tolerance very rapidly, and therefore it doesn't work. But also, I think there's a different set of expectations in the mind of somebody with addiction when they get an opiate and they're looking for something different than pain relief, and that colors their experience. So I don't always see opiates working well in patients with addiction. This is actually true of patients who don't have addiction, who have been exposed to opiates for long periods of time. They sometimes don't work as well. I think Dr. Christian will get into a little bit more information with that. People obviously have different effects. Sometimes they're paradoxical. One way that we can determine, just from anecdotal experience, if someone is going to respond normally to opiates is they ask them if they ever had them and what their response was. Believe it or not, people who don't have addiction, well, I don't want to use the word normal, we'll say the non-addicted population, when they're exposed to opiates, will experience fatigue, a little bit of nausea. They don't want to take it too much. They want to lie down on the couch and not do a whole lot. What happens to people? Does anyone here in recovery from opiate addiction? Yeah? Did opiates make you sleepy? No. What'd they do? The opposite, right? Gave you energy, you wanted to go shopping, mow the lawn, and fix everything in your life. And probably didn't work out all that well. The other thing is that I've noticed in patients who have painful issues, especially patients in recovery who have acute pain, and we treat them with opiates, sometimes in the short term, the experience is poor for another reason, and that is that the exposure, again, to an opiate medication creates a very high level of craving and misery to the person who is actually trying to remain sober. And I've heard people say this, and I'll never forget it, because I've heard several patients say that the craving was far worse than the pain. They'd rather have the physical pain of, usually this was after like a dental procedure or a minor surgery. And so it's something to think about when you've had experience treating patients who have addiction. Okay, true or false? If a patient ever had a substance use disorder, especially to opiates, they should never get any for pain treatment. False is correct. So it's really important, and this is something that Dr. Christensen and I try to teach other physicians and healthcare providers, that just because addiction is present doesn't mean you forget about pain treatment. And I get some ridiculous calls from the emergency room when someone who's in recovery has broken their leg and the bone is sticking out through the skin, and the doctor's like, well, they've had addiction, so I shouldn't treat them, right? Seriously, that's the level of anxiety that's out there. And the answer is no, you need to treat people appropriately. And if there's a medical issue, it's important that that's taken care of right away with appropriate treatment, with opiates if necessary. And later on, when they're stabilized, the addiction doctors will help, we say, clean up the mess, but kind of get the patient stabilized after that. And again, there's a misery and craving issue. So, true or false? If a patient ever had a substance use disorder, especially opiates, they should avoid self-administered pain medication. That means, is it a good idea to give them the bottle of pain medicine and tell them to take it as needed? What does as needed mean if you have addiction? This, yes, the whole bottle. So the reason this is true is that in what we know about the neurobiology of addiction, which is a different talk, that when addiction is activated, it hijacks a very important part of the brain that alters decision making. Therefore, when you're asking someone to make a decision about how they feel and whether they should take a chemical that alters that part of the brain, you can see how the equation will always be, yes, I need one. And it won't ever be able to make, the brain will highly unlikely be able to make a good decision regarding administration of that substance. However, in certain controlled situations, the substances can work reasonably well, especially in a high level of acute pain. Patients can have someone else, a nurse or a family member, kind of take over the pain control or the pain medication. Although I had a patient today in the hospital who has a history of opiate dependency, who has a painful condition, and the doctors were thinking about sending him home with a bottle of, oxycodone. And he's sitting there next to me. His wife is on the other side of the room. And he's going, and he says, well, it won't be a problem. We're going to give my wife the medication. And she's going, no. Because she knows what that's going to be like for her. So that does work, but you have to make sure there's support on both sides. It can be a very traumatic experience for the person who's holding on to the medicine for the loved one who's crying and is trying to manipulate to get it, which is part of addiction in full-fledged reality. So you have to make sure that it is a solid situation before you bring in a family member. There are certain substances, again, these are the things that those who are in recovery know and love: opiates, benzodiazepines, muscle relaxers. And we do believe that there's cross-addiction, cross-dependency, in that if someone has a specific drug of choice or drug of no choice, let's say it's an opioid, that exposure to other substances that activate the addiction center can reactivate addiction for that substance. So it's not to say, oh, it's safe to give someone Xanax if they have an opiate dependency, or that cannabis is going to be okay for somebody who has a cocaine dependency or alcohol dependency. These will likely reactivate addiction, especially in someone whose recovery is not super stable. And usually people who are using cannabis are having some questions about their recovery. Okay, true or false? Pain, whether acute or chronic, mild or severe, should be addressed in patients with addiction because failing to do so can jeopardize their recovery. True, yeah. So untreated pain, it is destabilizing to recovery. People who are in a lot of pain, we talk about hungry, angry, lonely, tired, but throw on like severe pain 24/7 and people are going to break down. And you need, so therefore, what Dr. Christensen and I do is we treat pain very aggressively and appropriately with other substances and other techniques to help reduce pain in patients with addiction. They should not be left in pain. It is very, very unstable. Another thing that occurs that we have to be aware of is occasionally, this may be a surprise, people who are in the midst of their addiction, they maybe don't take care of their bodies all that well when they're out there, right? And they will have all kinds of injuries and dental problems. And suddenly we take them off, say, a strong pain relieving drug, and what happens? Well, suddenly they're feeling all the things that have gone wrong, and we have to address those as well. That can be destabilizing. All right, so what is there to do? Well, one of the things you can do if you are in recovery or know someone in recovery who has pain or a medical condition that could be jeopardizing to their recovery is you can connect them with an expert. I am an addiction medicine expert, so is Dr. Christensen. There are also addiction psychiatrists that can be helpful on occasion. And having an expert on your side to help you through that is very helpful. Frequently in the medical system that I work in, a lot of the primary care doctors know that if they are trying to treat a patient who has addiction or early recovery or even long sustained recovery but has a medical problem, they can reach out to me and my group to get some guidance. But not everybody has that. So if you don't have that and you need that, you can always make an appointment, or you can have your primary care call for some assistance or help. You should, in general, any drug, even prescribed by a well-meaning physician, that alters mood, treats pain, makes you sleep, or makes you awake, are things to be concerned about. And that would, if you're in recovery or you're caring for someone in recovery and those drugs are prescribed, I would definitely recommend talking with an addiction medicine doc before that person takes that substance. Herbal remedies or natural cures are not completely free of problems. There are many substances, kava kava, valerian. There are a number of things that contain alcohol out there that you just got to be very careful about. And again, consulting an addiction medicine expert could be real helpful and perhaps avoid a painful outcome. When a person has a medical issue and they're in recovery, the best thing they can do is leverage the resources they have available. If you have a lot of supports in recovery, if you have a sponsor, if you have therapists, family members who support your recovery, bring everybody in to let them know or if you're in recovery, that you're going through a medical problem, and that perhaps your sobriety might be at risk, and to help you and to guide you. Increasing meeting attendance is extremely helpful. Boosting recovery engagement before a procedure, during a procedure, and after a procedure. Very, very important. When I have patients who are at any stage of recovery and concerned about exposure, I schedule appointments with them a couple weeks before, just after, and for several months at weeks or every other week intervals until they are through their medical issue and they feel that their sobriety is intact. And that's very important for getting through these medical exposures and painful situations. And now I will turn it over to my friend and mentor, Dr. Carl Christensen.
My name is Carl Christensen. I'm the medical director here at non-pharm, and just by way of identification, I have no financial relationships to disclose. The one thing I wanted to mention is that I'm a member of the advisory board of a great organization known as Families Against Narcotics, which has active chapters in Washtenaw and Wayne County, and probably pretty much all over Michigan. And if you are interested in hearing stories about family members, it's a great organization to belong to. And I want to start off by talking a little bit about the opioid epidemic and who is at fault. And there are a couple of well-known names that you should probably be aware of. The first is Dr. Russell Portnoy, who is an anesthesiologist from New York, who about 15 years ago, as a consultant for Purdue Pharmaceuticals, began promoting the use of high-dose opioids. And I can remember going to talks on chronic pain management about 15 years ago, and when someone like him would talk, you couldn't even get in the room. Nobody else, you know, this was the from on high, and he promoted the use of whatever amount of pain medication was needed. About 5-10 years later, this guy came along, Andrew Kolodny, who is a addiction doc like we are, and he is a member of Physicians for Responsible Opioid Prescribing. He's the founder, and his stance is that opioids should not be prescribed for more than a couple of days for post-op pain for any other reason, and you should only be allowed to take opioids for 2 weeks. So between those two zealots, you've got, you know, people in between. And then I also want to point out a guy named Joe Ranazisi, who's a friend of mine. He was the deputy director of the DEA. He was forced out of the DEA because he blew the whistle on legislation that was blocking the ability of the DEA to monitor big pharmaceutical companies. And last but not least, we have Rudy Giuliani, who was hired by Purdue Pharmaceuticals when they began getting in trouble. I don't know how much Rudy has helped Purdue or anybody else for that matter. But so I have all seen these slides if you look at Google News or anything. But this is what's going on with prescription pills, and this goes back down to 1999. And beginning a little bit after 2000, if you look at the line dotted labeled pills, we started seeing an increase in prescription pill overdose deaths, just steadily climbed up until about 2012, 2015. However, what really took off was heroin and fentanyl deaths. And really, when you say a heroin death, the majority of those are due to fentanyl. Because without fentanyl, heroin deaths in the U.S. have been steady at about 3,000 per year, and now those two combined drugs are more than 10 or 20-fold higher. So it's just skyrocketed. And if you believe the government, prescription pills are going down. The top line is all pills. The bottom line is high-dose pills, and there are fewer pills being prescribed out there. But despite that, and this is Michigan data from a company that monitors Michigan doctors, the top line are pills prescribed by Michigan doctors. It's going down. The bottom line are overdose deaths in Michigan. It's still going up. And the culprit here is almost certainly going to be fentanyl, as well as other drugs coming back, including stimulants. And what's going on here is prescription pills, numbers, doses, strengths, everything is starting to go down. However, overdose deaths continue to increase because of fentanyl. And you will routinely hear our patients tell us that their doctor got arrested, or they ran out of money, or lost their insurance, so they started buying heroin. And it starts off being cheaper, but really that 50% is now 75 to 100% of heroin specimens in southeast Michigan have fentanyl in them, and a lot of them have no heroin in them. And you can go out in Ann Arbor tonight and buy fentanyl from somebody. You don't know what you're getting. But we have a lot of patients who just deliberately go out and buy fentanyl, and they're not really concerned about the risk of overdosing. And the problem is the horse is out of the barn. We have created a generation of opioid-dependent people, and simply cutting off the supply of opioid pills may help the next generation, but it's not going to help this generation. They have already become addicted, and it might actually make things worse. And this is an article from the American Journal of Public Health, a doctor named Keith Humphreys, who's a very well-known addiction specialist, and they estimate the mortality is going to keep going up for 5 to 10 years. And it would be the same thing if we could magically make tobacco go away tonight. The people who got lung cancer, emphysema, COPD, all that stuff would still have it, and they would still be having deaths, and it wouldn't matter if the tobacco went away tonight or not. So who's responsible for this? And it's easy to blame Big Pharma, which we do a lot, and they carry a lot of the responsibility. This is a slide showing opioid deaths and opioid sales, and it's the same line, okay? And there's study after study showing sales, deaths, treatment, they're all parallel lines. And the assumption is that this is being caused by Big Pharma, and Big Pharma did do a lot of advertising. Same thing here, sales, deaths, and treatment are all identical lines for opioids. However, unless it either fell off a truck or you bought it on the internet, every opioid out there came from this. Here's an old-time Vicodin prescription, now replaced by Norco or hydrocodone, and these are especially important in Michigan because as a Wayne State grad, I hate to use the expression Big Ten, but Michigan is in the Big Ten. We are number 10 out of the country in opioid prescriptions per capita. We have 101 scripts for every 100 people, which means that everybody in this room got a script for Norco last year, which obviously is not true, okay? So when you ask why do doctors overprescribe, if you look it up in the science literature, you're gonna hear what we call the 4 Ds. Docs are dated, dishonest, duped, or disabled. And let's look at each one of these. So there are a very small percentage of doctors who are just crooks. And that's a very small percentage of the opioids coming out. And this is one of the pain mills that they had down in Florida. And you would simply go in, tell the doc what you wanted, you would pay cash for it, fill it at the pharmacy, and then sell some in the parking lot in the back. And the DEA is very energetic about closing these down, but it's like a whack-a-mole. If you knock one off, another one's going to appear. There are some doctors who are dated, meaning they don't know that you shouldn't prescribe high-dose opioids off the bat or start new patients on opioids without careful consultation, yada, yada. And I gave this talk once in northern Michigan, and after the talk, a doctor came up who was a lot younger than me and wanted to know what a benzo was. Okay, so that's, I mean, you do hear of docs who really have no idea what's going on. Physicians get addicted just like everybody else. We are probably at higher risk because of his exposure, stress, family history, trauma. And when someone is addicted and in active addiction, even if you're not acting as a crook, your judgment is just completely mush. Patients learn that very quickly, and they tell their friends who tell their friends. So pretty soon Dr. Christensen has a line around the block, and you hear about these places getting busted, and it's sometimes doctors who just don't have any cerebral function. But this is the big one, duped. We are people pleasers. I went to medical school because I wanted people to like me. No one's sure why Dr. Weiner went to medical school, but he's an exception. But people in healthcare want people to like them. There is nobody happier than someone leaving my office with Norco, Soma, and Xanax, and nobody unhappier than someone leaving my office empty-handed. And people get duped and doctors get duped. And one defense that will be used in court, whether it's true or not, is I was just listening to my patients and trying to do what was best for them. This is a famous video you can find on YouTube. It's the OxyContin promotion about how I got my life back. I took this picture off YouTube so you can see it. And these folks also are involved, the American Pain Society, which just went belly up, and JACO, the Joint Commission on Accrediting Hospitals, promoted the 5th vital sign. And any doc you talk to will tell you about making rounds in the hospital and going into a patient's room and saying, well, how you doing, Mrs. Jones? What's your pain score? And she's watching TV, talking on her phone, eating a sandwich, and she'll say, well, it's 12 out of 10. I need more. And you know that it's not appropriate to give Mrs. Jones more medication, and you leave, and you're intervened on by the hospital because they don't want Mrs. Jones stirring up a ruckus, and this can really damage your career. And I mean really damage your career. Fortunately, this is a lawsuit from West Virginia. They are suing JACO for being partially responsible for the opioid crisis. So we'll see how that turns out. Now, I thought I made this up, but I didn't. There was a doctor who beat me, Anna Lemke, who's an addiction doc out in California, and she brought up the idea of defamation based on social media. And you know that if you see someone tomorrow and you don't like how you're treated, you can just log on to your cell phone in the parking lot, go to vitals.com, and you can just blast that person and you can harm their career. And this is very, very concerning because the doctors' employers are also going on vitals.com to see what kind of things are out there. So here's the kind of things that I've read on the internet by docs, or about docs. Don't waste your time. 1 star out of 5. The worst doctor I've ever seen. 37% highly dissatisfied. This is the best one. He's a complete asshole, the controlling son of a bitch who doesn't listen to you. These are all about me, okay? And I didn't mention, but my direct supervisor is Dr. Weiner here, so I think he always worries about these things showing up too.
I feel bad because I wrote it.
Now, eventually, these guys get involved, and Tenacious does not begin to describe the DEA. If they believe that something is wrong, they will just keep on plucking away until they find something. Now, this is an example of a case in California. This doc knew that there were some people watching him, so he began requiring an x-ray to prescribe you OxyContin. And a patient brought in their x-ray, and actually it does show something abnormal. The right hip is dysplastic. It doesn't fit in the socket. So that is almost certainly painful. The other thing is the coccyx is very long. Most of us would call that a tail. This is a dog, okay? And what happened was the doctor said, I can see why it hurts, you know, what do you want? And the patient, who was a DEA agent, said, you know, I want OxyContin or oxycodone, and the doctor got arrested, and he's not practicing anymore. So the bottom line for anybody who writes you a narcotic is something called the Controlled Substance Act. And there's a line in there that is written that says it must be legitimate, which means it's for pain mostly. It must be done in the usual course, which means they watch you, they make sure you're not diverting, they make sure you're not addicted, and it cannot be prescribed for opioid dependence, meaning if your doctor thinks you're addicted, they can't keep prescribing you Norco. They have to stop according to the DEA. So let's talk about the opioid crisis. What has happened? As you may have heard, we're going to talk about this. In 2016, the CDC released a set of guidelines for doctors to follow called the Opioid Prescribing Guideline for Chronic Pain. And it had like 12 guidelines in there, kind of like 12 steps. And it was not only rapidly adopted, it was taken as gospel. And I'm going to show you what went wrong. One thing is that as a result of this, without evidence, doses were cut down in the U.S. forcefully without patient consent, and sometimes resulting in patient suicide and resulting in heroin addiction. And there's a glossary you guys have, but MED stands for morphine dose. We always compare everything to morphine so we can compare different medications. Some brand names were excluded by insurance companies. The most famous one is OxyContin. Some laws in Michigan, for example, say that you can only prescribe for 7 days for acute pain, and then you have to get a brand new prescription. We'll look at that. And you have to have a special relationship with the person who is prescribing, and you have to do what's called a MAPS, or a Michigan prescription search, so they have to know who else you're seeing. And this gets some patients very upset because they think it is an invasion of their privacy, but it's required by law. Unfortunately, the most important thing we could do, they don't recommend increasing, and that's drug screens. Drug screens are invaluable for determining if somebody has pain or addiction, and if they have addiction, Norco is not the answer. And in Michigan, at least, there is increased availability of addiction treatment by law, and also hopefully by federal law. The worst thing we're going to talk about is patients are being forced off their pain meds. So where did this dose restriction come from? It comes from Guideline 5 out of the CDC guideline, and this guideline does point out that opioid deaths are related to dose. There is no way around it. But what the guideline says is when you start somebody on medication, use a low dose, Try not to go over 50 milligrams of morphine, and definitely don't go over 90 milligrams of morphine. It didn't say anything about somebody who was already on 90 milligrams or 120 milligrams. An insurance company sees that and said, we are going to force your patients down off that dose. I have had pharmacists refuse to fill a medication prescription because it was more than 50 milligrams of morphine, just out of nowhere, okay? So that's what went wrong with this. However, you have to realize that dose does predict death, and if you're on more than 100 milligrams of morphine, you're 9 times more likely to die than if you're on 20 milligrams or less of morphine. And this is one big study, but it has not been repeated in patients who are stable and who are not mixing medications, et cetera. So this is not gospel. This needs to be repeated, and it really has not been. It's been hystericized. Why stop different formulations? Now, I have a lot of friends and patients who have tattoos, loved ones, military service, grad school, whatever. I don't know any of my friends who have OxyContin 80 milligrams and a syringe tattooed on their arm, okay? We call that an abnormal relationship with your medication when you have a tattoo of it on your arm. And for that reason, and also because things like OxyContin are much, much higher dosing, those have been taken off the market pretty much. How about this forced tapering stuff? This is just one example I found on the internet. This is a managed healthcare organization that they had a statement, in almost all cases, tapering should be done. Okay, that's just it, like you're coming down no matter what. And in Oregon Medicaid, who you can argue are the most vulnerable patients, has decided that their patients should just come off opioids. And they quote our buddy Dr. Kolodny, and if you want to hear somebody get excited, listen to him make a speech. And it's very difficult to really determine how scientific this is. But the original Oregon plan was everybody off opioids if you're on Medicaid. This has resulted in suicide. This is a paper from 4 years ago from the Mayo Clinic, noting that increased suicides occur in patients who have affective symptoms, which in English means patients who have co-occurring psychologic or psychiatric disorders. And here's some examples that Dr. Weiner and I hear about for what would be considered abrupt discontinuation or a forced taper. Here's your last prescription, meaning typically 30 days. You got 30 days to wean off this medication that you've been on for 5 years, okay? Not safe, and as I'll show you, not recommended. Here's enough medication to make it to see Dr. Christensen, and then you're on your own. Medically, this is not legitimate because Dr. Christensen has not agreed to assume your care. Dr. Christensen doesn't prescribe opioids. I'll work with your doctor in tapering your opioids, but I'm not going to take over your opioid prescribing. And this means that you are left out in the cold if we can't agree on a plan of action. This is a case where a doctor gave a patient a medical marijuana card, and then when they tested positive for marijuana, kicked them out of their practice. Okay, that's questionable cognition, I think. And this is something that happens far too often. You tested positive for heroin, you're discharged, get out. Okay? It may be true that they should stop prescribing you Norco, but not that you should be kicked out of their practice. And this results in complaints of patient abandonment. Here's our friend, okay? And this occurs when you have a relationship with a doctor, you're cut off suddenly, you still need the treatment, you don't have enough time to find somebody else, and you suffer some kind of harm. And then this is going to lead to lawsuits. And these are rapidly appearing on the horizon. Now, this is from the Human Rights Watch. This is an organization that normally deals with calm places like Syria, torture, imprisonment, violation of human rights. And they're talking about the U.S. now. Okay, and they say that because of the opioid tapering and cutting patients off opioids, that we are violating human rights in the United States. And it's difficult to argue with this when you hear stories that during the interviews they get with patients that were cut off from their opioids for no valid reason. So after a couple starts and stops, this finally came out. This came out 2 weeks ago. And this is Health and Human Services, and they acknowledge that harm has been done, patients have died, heroin addicts have been created. So this is their guideline for taking people or tapering people or discontinuing off long-term pain medication. Again, we're not talking about the 7-day prescription. But you should discuss and consider tapering opioids if the patient is not getting better. You know, my pain's still 10/10. I still can't get out of bed. I'm on 100 milligrams of morphine. This is not working. Again, if the dose is high and there's no evidence that I'm benefiting from it. If there's evidence that I'm misusing my opioids, and this is up to 45% of patients in pain clinics in the scientific literature. If the side effects of the opioids impair my quality of life or actually make my functional level worse, I just don't get out of bed, I sleep all day. If I have an overdose or I have excess sedation, and often that information comes from the family, our dad just stays in bed all day long, he sleeps 20 hours a day, and the next thing you know is they're dead from an overdose. There are medications that should not be mixed with opioids. Dr. Weiner already mentioned them. Benzodiazepines, there are medical conditions that make opioids dangerous, and the most common one is having lung disease, because that's how opioids get to you. They make you stop breathing. Or somebody has been on opioids for years and years and they don't know if it's helping, and they want to see if they can come off it because they don't want to be on this stuff. There are significant risks to coming off opioids. Major withdrawal. Not as dangerous usually as sedative withdrawal, but it can be significant. Your pain can get worse. Psychologic distress, suicide thoughts, and suicide attempts. You turn to street drugs, heroin, so now you are labeled an addict. And unless there's a life-threatening situation, the government does not recommend abrupt opioid dose reduction or discontinuation. They just come out and say it. And I love this statement. Avoid misinterpreting cautionary dosage thresholds as mandates for dose reduction. What they're saying is, it's your fault. You misinterpreted our guidelines, even though they were poorly written, and all this has happened has been because you've misinterpreted the guidelines. And they quote guideline 5, which I just showed you, and if you read the fine print, they say, well, we're not talking about chronic long-term opioid patients, but it's kind of like when you buy a car and the agreement is like 15 pages long. It's on page 72 or something of the guideline. Patients on benzodiazepines may need to come off opioids because that triples your risk of dying, and it's incredibly difficult to do, and you should coordinate care with another specialist, and usually that means referring to an addiction doc. Don't dismiss patients from care, okay? They just come out and say it. And when I talk to doctors groups, I tell them, you may stop writing for the opioid, but don't kick the patient out of the practice because you may be held responsible for what happens to your patient. And it is dangerous to force a patient down on their opioid dose. If you are depressed, you're more likely to fail a taper, so consider a behavioral health consultation, which means a psychologist or a psychiatrist. And if you find that as you taper, your patient develops addiction, then you have to refer them from addiction treatment, and this guideline recommends medication-assisted therapy, which we just talked about a couple of weeks ago. Pregnant patients should go to a specialist. This says go on MAT, that's nonsense, but they should go to a OB specialist. There's only 2 docs in Michigan who are board certified in OB and addiction medicine. I'm one of them, the other one doesn't want his name given out, but your doctor can find a high-risk OB specialist to go over this with someone who's pregnant. And warn your patient that if you're tapering down and you say, I can't take it anymore, so you decide to take yourself back up to your old dose, it can kill you. It happens in people who get out of treatment, who relapse, they've been off opioids for a long time, they go back to their previous dose of opioids and it's fatal. So how fast are we supposed to do this? 10% per month possibly, okay? I showed you that slide of the guy who gave a 30-day supply to somebody. If you're going to do it fast, 10% per week, but once you take off the top third, then you slow down. And you stop when the patient is uncomfortable and then restart later. And as you get towards the bottom, you space out the interval between decreases. This is something that takes months to easily a year. And this is not unexpected to someone who's been on opioids for years. There's something called ultra-rapid detox, where you're put under general anesthesia, you're given an opioid blocker, which is supposed to remove the opioids from your brain. You wake up in horrible withdrawal, and the side effects can be lethal. It's not recommended by current scientific evidence. I'm not going to go over these, but there are medications that can help with detoxing off opioids that are non-narcotic. And at the other end, if someone gets off opioids, they can take a small amount of a medication known as naltrexone. It's called ultra-low dose naltrexone, and it's an opioid blocker, but somehow it helps with pain once you're off the opioids. And this is brand new. It says, if nothing else works, consider buprenorphine. And I'm glad to see this. This is what Dr. Weiner and I do mostly for a living. We get people off regular opioids, and we often use buprenorphine. Now, buprenorphine is available in different forms. What you commonly hear is Suboxone, Subutex, Zubsolv, that's used for addiction, and it may treat a condition known as hyperalgesia, which in English means it makes your pain worse. So your pain medications are actually increasing your pain. And this has been shown to happen over and over again in research studies, and a lot of this was done at U of M as well. It is safer than regular medication. It's still dangerous if you mix it with alcohol or sedatives, and it should be done, according to the government, by somebody who's experienced in buprenorphine. And really that comes down to addiction docs. So if your doctor wants you to consider going on buprenorphine, you're going to be sent to an addiction doctor, but you may not have any addiction. It also claims that it's easier to come off buprenorphine than other opioids. However, that is not true. Buprenorphine is very, very hard to come off of, and I have people who've been trying for years. It's not a harmless drug. And these are two papers that have been published on using buprenorphine for chronic pain. The one on the right, Dr. Weiner is one of the authors. He'll autograph your handout at the end if you want. The other one's from Dr. Malinoff here in Ann Arbor, and they showed that using buprenorphine for patients on opioids for chronic pain can be very successful. And not only that, if it turns out you either were forced into having an opioid use disorder or you already had an opioid use disorder, it is approved by the FDA to treat an opioid use disorder, so there's not going to be any problem there. Typically, when people are getting in trouble during a taper, they will lose their prescriptions, they will come in for early refills, they will start showing crazy things on their drug screens, and that tells us that things are not going well. Now, there are two times when the CDC recommends abruptly coming off your opioids. One is if you are selling them, okay? And the CDC says, you know, we don't want to interrupt your cash flow, but if you're not selling them, if you're selling them, there's no reason not to simply stop your prescription. And another reason is that you've been diagnosed with addiction. So if you've been prescribed Norco for a couple years for back pain, and it turns out that you really have opioid dependence, your provider cannot continue to prescribe it for you. It's against the law. Otherwise, the government no longer recommends abrupt discontinuation, period. Okay, where are we? All right. So I just want to go briefly over the new Michigan opioid laws. They came into effect last June. They were finalized this March. And if your physician is exhibiting any bizarre behavior, it may be because they're trying to fulfill these laws, because they are very confusing. Basically, it means your doc is supposed to do a prescription search every time they write you for a controlled substance. They have to get a consent form from you. You may have been given a start talking form, which says that you understand that if you sell your pills, you'll go to prison. If it's a minor, the parents have to be involved. They can't prescribe for a minor unless it's an emergency. You have to see somebody who has a relationship with you. If you go to a pill mill, things may turn out very badly, and there are still pill mills around here. Drug testing, unfortunately, is not required. And here's what can make you crazy. If your doctor doesn't run a prescription search, they can only prescribe you 3 days of pain meds. Okay? If they do write a prescription search, they can write for a whole 7 days. And that's for acute pain. And every 7 days, they have to rewrite a new prescription and send it in electronically, or you have to go to their office. Why did that happen? That created, the polite term I'll use is firestorm. Why did that happen? The reason is, this is research done right here in Ann Arbor at U of M by Dr. Chad Brummett's group. And what they found was, if patients are not on opioids, but they're given a prescription for a surgical procedure, 6% of them become dependent. Okay? Now 6% doesn't sound like much until you realize how many millions of procedures are done in the US every year. And who does this happen to? It has no relationship to what dose of pills you were given, the strength. It has no relationship to what surgery you had. That makes no sense. So DNC is has higher risk as a hysterectomy. Okay? That makes no sense. So who does it happen to? It happens to patients who have risk factors for addiction. And that tells us what's going on. I think what's happening is we are triggering the underlying potential for addiction in these patients, and they can't get off the meds. This is also from the government from 2017. If I give you a 7-day prescription, there is a 5 to 15% chance you're not getting off that medication. If I give you a 28-day prescription, which sounds crazy now, but we used to do it all the time after surgery, there's a 15 to 25% chance you will be hooked, okay? And again, same thing, this is believed to be activating patients' addiction. We should always talk about Narcan. For those in the audience who are old enough, and I think I'm probably the oldest person, second oldest person in the audience. We have always used a very low dose of Narcan for overdose from opiates or heroin, and it's always been 0.4 milligrams. I used that back in the 70s at Detroit General Hospital. However, due to the fentanyl epidemic, we now use 4 milligrams, which is the lower left, and that is a very commonly used form of Narcan spray called Adapt, and you get two in the container, and you are allowed to get a prescription now or go buy the medication if you have someone in your family that you think may overdose, or we can write a prescription for the patient and they can give you the medication to watch them. And this is our therapy dog, Olive, on the lower right. Not everyone agrees on this. This was a paper published on the internet that said, all they're gonna do is come back and steal your tires, so don't use Narcan. And they claim that Narcan makes things worse, okay? And this is a very inflammatory paper. It still hasn't been published officially in a journal, but these are two PhDs from different parts of the country who said that Narcan is bad for the US. Don't use it. And for example, this was a picture from a couple of years ago, I forget, it was Ohio or something, where a mom was found overdosed in her car, and while they were getting ready to resuscitate her, they took a picture of her and then arrested her. And this is 3 years later on the right. She says that her life was saved by Narcan. She went to treatment and she now has custody back of her kids. So there are success stories when this medication is used. There's no doubt about it. Okay, marijuana. Does marijuana make things better? You probably saw one of these billboards before last year's election saying that in states that had medical marijuana laws, there was less mortality. Is that true? Now, the first thing is, do people use less opioids if they're using marijuana? And this is a study by a famous researcher at U of M, Daniel Clow, and they claim that their patients who went to a medical marijuana clinic over on State Street used 64% less opioids. Now, this is not strong research. It needs to be done over and over again, but if it's true, it'll be fantastic. Another study claimed that if you're on Medicare in a medical marijuana state, you'll use 11% less opioids. Okay, whatever. But the biggest study of all, a national epidemiologic survey, found that people who use cannabis use more opioids, both prescribed and illicit. It made things worse. And this is the biggest study out of all of these. Now, how about mortality, dying? This is the study where that billboard came from. Dr. Bachhuber, 2000 to 2010, found that there was 24% less chance of dying if you were in a state that had a medical marijuana law. But, you see a lot of these, but a follow-up study that just got published followed it out from 2010 and found that things actually got worse, not better. And here's the study. If you look at the black line and the red line, when the black line is under the red line, it's safer to be in a medical marijuana state. When the black line is above the red line, it's worse to be in a medical marijuana state. The arrow points to when Dr. Bachhuber did his research, and in 2014, it crossed the line, and now you're more likely to die from opioid overdose in a medical marijuana state. Somehow, this didn't get put up on the billboard before the election. Is cannabis addicting? Yes. 7 to 15% chance of addiction, more severe addiction in adolescence. In adolescence, it may be associated with schizophrenia and a drop in IQ. Is there a withdrawal from marijuana? Oh, yes. Ask anybody trying to come off it. It's persistent, prolonged, and the success rate is low. Is it safe during pregnancy? No. Okay? It's not more dangerous than tobacco, but it's not safe. And is it safe to use while driving? No. States who have legalized marijuana clinics had a big increase in mortality in motor vehicle accidents. And this is a study done again at U of M, interviewing patients on medical marijuana, and it said that 22% of medical marijuana patients admit to driving while really high. And I would expect that somebody who's a medical marijuana patient, when they say they're really high, okay? Not safe. And I love this picture. This came out earlier this year. This is a guy who was, I think, rolling a joint and lighting it and drove right into the back of a state trooper and didn't even try and conceal it. And this picture is, you know, stoner meets state trooper, and the state troopers won. Okay, so basically, if you have pain, chronic severe pain, it's not likely that you will be started on opioids nowadays if you are not on them already. Why? Because number one, they don't work. Number two, they're not safe. Number three, the doctor is putting a bullseye on their back, okay? If you're already on opioids, the government says they can continue on opioids if you discuss it and talk about the possibility of a taper. Or your provider may want you to come down below that magic 90 milligram line because that's already been out there and insurance companies are trying to force it. Or they may cut you off and bad things may happen. Or you may be referred to a pain specialist or an addiction specialist for your tapering. And again, remember that if you're sent to an addiction specialist, it doesn't mean you have addiction. Now, when you meet an addictionist, if you're not already on opioids, don't expect them to start, again, for the same reason. And also, they may be concerned about why you were referred, because some providers that refer patients are not always completely truthful. If you go to an addictionist and you're already on opioids, they will probably not keep writing for the opioids, again, for the same reasons. They may offer you buprenorphine, and there's two different ways it comes. It comes in a patch, which is very expensive, weak, inadequate, and insurance companies won't pay for it. Or you may be offered the regular kind of buprenorphine, which is Suboxone or Zubsolv, and that can be used off-label for chronic pain. Now, one thing we didn't talk about really was the hyperalgesia. This is one study that showed that if you get your patients off pain medications, look at the decrease in the pain score. On the left is before, when you were on opioids, the pain score was 8. after coming off opioids, the pain score is less than 4. That's an enormous difference. So it may help to come off the medications. All right, so these are, on the right is Stan. Stan was one of our therapy dogs at our old office. He was blind and couldn't walk, but he was our ladies' man. And on the left is a rescue we just got from Tennessee. He's old, kind of blind, and his owner was going to shoot him. So I think Lucky is an appropriate name. He's up with us now. And Dr. Weiner and I can answer any questions you have. Thanks. So the question is, that graph I showed about the pain score going down off opioids, that would be off Suboxone. They may have used Suboxone to get off, but it's off Suboxone. Methadone and buprenorphine, people don't tend to develop tolerance because it works on an extra part of your brain. So the question is, what about addiction to benzodiazepines? It is a terrible condition. It is rated as very low abuse by the DEA. It should be at the very top. The government recommends if someone's on opioids and benzos to take them off the opioids because it may be impossible to take them off the benzos. And both Dr. Weiner and I can tell you about patients that have gone through horrible withdrawal for long periods of time, no matter what medication you use. And it's a very difficult medication to come off of, and really should be avoided whenever possible. So the question is, what about abrupt benzo withdrawal? It is similar to abrupt alcohol withdrawal. So you shake, sweat, become agitated, your blood pressure goes up, your body goes into overdrive, you get confused, and if it gets bad enough, you have a seizure. So the question is, does it take a while? And depending upon the benzo, it may not happen for a week or 2 weeks. Yes, especially something like Valium or Klonopin, which wears off very slowly. So the question is, what do you think about frequent drug screens or very common drug screens? That same emergency room you go to will probably ask you questions about depression and take your blood pressure and ask you about domestic violence. And I think they should either screen, or if they want to do a questionnaire or do a drug test to look for drugs of abuse, because that is one of the most common, if not the most common reason to wind up in the emergency room. Marijuana, cannabis withdrawal, you can have agitation, insomnia, confusion, irritability. It is prolonged. And, I meet patients who will say, I take cannabis to prevent my morning sickness, and I'll point out they had their baby 6 months ago, okay? And if they don't use cannabis, they start throwing up. Or if they use cannabis, they start throwing up. It can go both ways. So there are physical side effects as well as psychological, yes. No, I don't taper anybody off cannabis. They may have to go into a residential treatment program if they can't stop as outpatient. And there is no really effective medication for cannabis right now. So the question is the use of cannabis increasing in the older population?
Yes.
Is it? And I would suspect that the underlying reason might be pain. I don't know. So according to National Institute of Drug Abuse, the overall addiction rate is about 7%. In adolescents, it can be about 15%. People who were using cannabis had a higher incidence of opioid use, both prescribed and illicit. There's a lot of possible explanations, but there was no decrease in opioid use, which is what's been claimed. So the question is CBD without THC safe for addiction? The problem is that the only way that you will know that you are getting pure CBD is a drug called Epidiolex, which is for childhood seizures. It's about $7,000 a month. And when you buy THC-free CBD oil, in one study, 14 out of 15 volunteers tested positive for THC after they used THC-free oil, and the chance of you testing positive for THC is quite high. And as far as, is that enough to trigger someone's addiction? I don't know, but my policy when I talk to patients in recovery is safety first. You also are jeopardizing your job. So you have to be aware that in the state of Michigan, an employer does not have to accept a medical marijuana card. And if you are tested and test positive, both Dr. Weiner and I have seen tons of professionals who come in after losing their job for testing positive for THC. So hemp oil is by definition less than 0.3% THC, but the majority of those products you will still test positive for THC. And you can argue that the level is too low to have any effect upon you, but that's that's like an alcoholic drinking O'Doul's. That's a risky proposition if you're in recovery. So the question is, what about completely non-pharmaceutical pain management strategies that we use? And the answer is yes. The ones that have some evidence are going to be acupuncture, chiropractic, massage therapy, deep cranial stimulation, aromatherapy has been used. The evidence for all of these is not strong, but patients will frequently have some response to them. But as far as strong evidence, when you read review articles, they say that, there's not enough evidence to show that this definitely helps. But remember that if you're talking about risk, there's very little risk to these therapies. So the question is, what about exercise and opioid withdrawal? This is something that has been shown to work, and there is a big movement now, the Orange Theory, right? Yeah, there's a big movement now for strenuous exercise with opioid withdrawal and treatment for opioid dependence. Not covered by insurance. Kratom, well, thank you. So the question is kratom. So kratom is a herbal remedy from the well-controlled pharmaceutical industries in the jungles in Thailand. I have had patients who told me they were using kratom, didn't test positive for anything else, and all of a sudden popped up positive for fentanyl. I have a lot of patients who had long-term recovery, who were just kind of feeling down in the dumps and decided to try this herbal remedy because it gives you energy, and they are now hopelessly dependent. I have pregnant patients who can't get off kratom. Any claim you hear that kratom is harmless and easy to stop is simply not true. It's an opioid. It's been classified as an opioid by the FDA. It works on opioid receptors. It has stimulant properties, and it's addictive. So if someone says, well, it's safer than heroin, it may be until you start buying some that has fentanyl in it, in which case you're in the same danger zone. All right, so we'll stick around afterwards, and thanks for listening.